Malawi's experience of the COVID-19 pandemic stands out in several ways. SARS-CoV-2 transmission and immunity in Malawi is poorly understood because of very limited routine diagnostic testing and a significant amount of asymptomatic infection. This means that the confirmed case number only reflects a tiny fraction of the true transmission. Also, the vaccination campaign in the country faced difficulties, meaning that rollout was delayed with comparatively low coverage. To really understand what was going on, we turned to serosurveillance, which means that we looked at the antibodies people carry after infection or vaccination. These antibodies let us track who have been exposed and the strength of their immune response. But here's the problem. In Malawi, previous serosurveillance studies were primarily based on convenient, non-representative samples and relied on measuring IgG antibodies, which don't tell us whether the antibodies can neutralise and protect against the virus. There were some big gaps in our understanding, and that's what we set out to fill. We designed a population-based longitudinal serosurveillance study in 2 regions of the country, Lilongwe, the busy capital city, and Karonga, a rural district along Lake Malawi. We followed almost 2,000 participants from February 2021 to April 2022, checking in and collecting serum across 4 study surveys. We captured the Beta, Delta, and Omicron waves, and the gradual rise in vaccine coverage. To measure functional immunity, we focused on neutralising antibodies, which are the proteins that stop the virus from infecting the body cells. For participants without HIV, we used an HIV-based pseudovirus assay, but for people living with HIV, we switched to a vesicular stomatitis virus system because HIV treatment can interfere with retroviral assays. We also looked for antibodies against the virus's nucleocapsid protein to help us work out which vaccinated participants had also been infected. What we saw over time was an increasingly complex immune landscape. Early in the study, neutralising responses were mostly directed at the original viral strains. But as Delta and later Omicron swept through, the pattern shifted and the picture changed. By our final survey, Lilongwe had much higher levels of neutralising antibodies, around 68%, compared with 45% in Karonga. This likely reflects differences in population diversity, movement, and access to vaccines. People who were both vaccinated and previously infected had the strongest neutralising responses, and those who were only vaccinated showed robust immunity still. But people who'd been infected but unvaccinated had noticeably weaker responses. 2 findings really stood out. Firstly, children under 15 who'd been infected but not vaccinated had surprisingly low neutralising antibody levels compared with other age groups. Secondly, people living with HIV showed reduced neutralising responses, especially after vaccination, highlighting a real vulnerability to reinfection. Taken together, the message from these data is pretty clear. Vaccination is key to building these strong, protective immune responses. When it comes to public health priorities, children and people living with HIV appear to be groups who may benefit from ongoing monitoring. Finally, ensuring vaccination and boosters for people living with HIV could make a real difference by strengthening protection in this vulnerable population.